Hi, I'm Jack Cush with rheumnow.com. We're here at the Rheumatology Winter Clinical Symposia. Artie, that's called what?
RWCS, it's our 14th year.
There you go. So it's been a very good week. RWCS has been a live on-site meeting and a streaming meeting to those of you out in the netherworld. Exciting meeting. So in this week's edition of the RheumNow podcast, we're actually going to do a recap of RWCS 2021. Artie, give us a general impression of the meeting overall.
Overall, of course, I have a bit of a bias. I have a dog in this fight, but I think it's been great. I think it's really exciting to hear how many new things there are really across rheumatology, across diseases, across diagnosis and prognosis, and of course, especially regarding therapies.
And it's been thrilling to actually show that we can be back in the medical meeting business again, that we can have live meetings. The audience, we have a low number of people are here. They're appropriately spaced. Everybody's wearing a mask, but we're still in a meeting location. We get to be with colleagues, talk to the speakers, have lunch with the speakers. It's been really exciting, and yet we've still had some of our great speakers, Eric Ritterman and Marty Bergman and Alexis Ogdi and others, beaming in and being an active participant in the meeting. I think it's very refreshing that maybe we're turning the corner on how we're going to continue our education in rheumatology.
Yeah, it's tricky, and it's taken a lot of work by the technicians who've done an outstanding job of bringing together speakers who are remote and speakers who are live for an audience that's remote and also an audience that's live. And it's, I think, actually a lot trickier than doing either a fully live meeting or a fully virtual meeting.
Yeah. So we have 3 out of the 4 meeting days under our belt. I thought we'd review some of the highlights of this meeting. Artie, in day 1, you and I started the meeting off with a rheumatoid arthritis year in review. Again, a lively discussion. I think one of the things that I got a lot of questions about afterwards was our coverage of the whole steroids issue in RA. We had the Samira study that showed whether or not you should wean off prednisone or stay on prednisone, and yeah, you can wean off, but you do better if you stay on prednisone with in RA. And then 2 other studies showing that even 5 milligrams or less carries an infectious risk and a cardiovascular risk, sort of ruining our ideas that really low doses don't matter too much, but still steroids are big in the conversation. What's your feeling on that?
Yeah, I think that's true, and it's true across diseases. One of the other presentations that we highlighted was from Iceland, the IceBio, which showed that this isn't just a US thing, that rheumatologists across the world use corticosteroids, and we like to think that we get all of our patients off, but we don't. We still use lower doses of them. And then today in the case presentations, everybody was on corticosteroids, it seems, at some point in their presentation, and that's, I think, the ongoing discussion. Is there a dose that can be potentially safer than some of the alternatives that we might have for an individual disease state?
I think some of that is real need. I think that, these diseases are complex and need combinations of therapies, but I think there's got to be some percentage of patients in there where we're just forgetting and getting a little too lazy, a little too complacent, and we're continuing even that low dose of steroids when maybe we shouldn't be on that. Michelle Petrie and others in the lupus world are saying they don't really need steroids to manage, difficult disease anymore. We have enough treatment options that maybe we can get beyond that. And if you're going to use expensive therapies like TNF inhibitors, like in the IceBio, maybe you should be able to get off.
That should be the goal, for sure.
Yeah. What else did you like from our session in the review session?
Well, I think the safety issues are always great importance, because it's easy to cover a randomized controlled trial. The data are the data. You see how well a drug works. Safety is trickier. You get a little bit of information from the studies, and we talked about the select choice, which compared 2 different mechanisms head-to-head, a JAK inhib and a T-cell inhibitor. But then the other issues that came up, and sometimes you don't have the answer, which is great to discuss in a format like this, where you get with your colleagues and say, what do you think of these data? And that's the data from the JAK inhibitors about, do they have a signal for cardiac events, for malignancy, for venous thromboembolic disease, an important and evolving story.
Yeah, it seems like it just keeps coming out in drips. You know, we got first the thromboembolic risk drip, and now we got there's maybe a MACE, a major adverse cardiac event drip, and now there's a cancer story. But the FDA is not telling us the data. They're saying they're looking at it. And in the meantime, what are we supposed to do? I think we still just have to wait and see what happens. Again, this was a long-term, you know, it was a 5-year, 6-year safety study of, you know, thousands of patients at high risk over the age of 50 with a cardiovascular risk factor. So it's not surprising some of these things happen, but it is surprising that it's come out this way. The other thing I liked about the safety that you covered was is the risk of lymphoma actually changing over time with better control. So, you know, the old data that was reviewed by the FDA in 2003 showed that RA patients are at higher risk of lymphoma, and but not nearly at a higher risk of cancers, and that RA patients going on TNF inhibitors are also at the same higher risk, but that historic data showed that that risk was often uniquely related to activity. And then this new report from the Swedish registries showed that over time, in recent years, that the SIR, the standardized incidence ratio, has in fact gone down, got closer to 1, suggesting that if you do control inflammation, maybe you do lower lymphoma risk.
Well, and it's important for us in rheumatology. It's also important in GI. IBD is in many ways every bit as bad as RA in terms of these bad outcomes that are associated with active disease. And if you take away the activity disease, the patient should be better, and maybe we can avoid some of the toxicities like the increased risk for lymphoma.
Yeah. Which else did you like from the sessions?
So the first day, what I really liked is a presentation by Dr. Anna Postolova, who's a rheumatologist and also an allergist immunologist, and she participated remotely, but we were able to really discuss things a lot, and that was a presentation on IVIG. And although it's IVIG, it's some incredibly practical information about differences in the preparations and theoretical constructs. But one of the things I thought was most interesting is that one of the things they're doing with IVIG as replacement is they're actually using it sub-Q. And that's much easier. Potentially could be much more cost-effective than doing it intravenously. And I'd like to see the uses of IgG given subcutaneously to see if that might work for a disease like myositis, where I think all of us believe it can work.
Yeah, I mean, we covered both at ACR and also on RheumNow the results of the recent trial, head-to-head placebo-controlled trial, showing that IVIG really does work in dermatomyositis. I think Anna's lecture sort of helped to demystify a lot of what's around IVIG. I think and knowing where it works helps. I think it still would help if we had a little better definition of where exactly it should be used over steroids or instead of steroids or instead of a particular immunosuppressive. But it was a really, I think, the audience liked it because it gave them, I think, a better level of confidence with that. I liked, there were a few presentations both from ACR and we discussed here on machine learning. You know, machine learning seems to be taking on a bigger role in medicine and certainly in rheumatology, where it's all about how you handle big data sets and can you analyze big data sets in a way through artificial intelligence that will help inform better decision making. So, you know, there were machine learning studies about better use of DMARD choices and machine learning on imaging and spondylitis. What do you think of those? Yeah,
I think it's in complex heterogeneous diseases like almost all rheumatic diseases, there's not quite a simple answer. So I think we need different approaches that will take as much data as possible to try to make the best decisions for the choice of therapy. And the imaging, I think that's coming. I can't imagine that that's not coming. Our radiologists may be in for a tough time because I'm not sure that that we'll need as many of them if the machines become good enough to read it, and for us to give a scoring system where we're looking for very small differences to see if a disease is progressing, and machine learning would be very important for that. That's something we miss clinically.
I'm at odds with a lot of our rheumatology brethren on the issue of x-rays and imaging. I don't do them. I do them to establish diagnosis to establish disease state and have a baseline. I don't do repeated annual imaging. I don't do much in the way of MR. And my main gripe there is I'm good at those things, at looking at them, but I'm not formally trained. I can't score them. I usually don't have the old x-rays around. But to have, again, a computer that can actually do the reading and score it for me in a truly reliable manner could be a major advance in medicine.
Well, when I was a resident, I trained with Dr. Lidsky in Houston, and he was a brilliant man and just a professor, old gentleman. And he is the other person on the article with John Sharp. So the Sharp score is really the Sharp-Lidsky score, but wow. As John Sharp once told me, Martin didn't like to write. But every year he would get x-rays on all of the patients, and so he followed them over time. Now, we don't do that as much, but I got to say, in the clinic, sometimes I'll see someone and I haven't gotten an x-ray in 5 years. And it's a lot worse. And the problem is I don't know when it got worse. Mm-hmm. And I try to make treatment decisions. And if they've always been bad, then I say, well, they're always bad, doesn't matter. But sometimes I say, gosh, I wish I had some x-rays in between. And with machine learning, I would really say, well, then I'll be able to treat it as data. That yes, this is worse, not just really grossly worse like we would pick up looking at the x-rays ourselves.
Through Artie, I got to meet Dr. Martin Lidsky. He was a pistol. He was pithy and insightful, and when you were with him, you knew you were going to learn something, and he made sure of that. I think I'd have Dr. Lidsky over machine learning any day. So on day 2, there was this great presentations by, I guess it was Alexis Ogden and Eric Ruderman about etanercept's use in non-radiographic axial SPA. So we have 3 drugs currently approved for non-radiographic axial SPA: certolizumab, secukinumab, ixekizumab, and now etanercept's throwing its ring into the hat with a well-designed trial showing that it worked. And then they confused me by doing the next study showing that etanercept didn't work in something called pre-SPA. And the difference being that the non-radiographic axial SPAs had inflammatory back pain, the clinical symptoms you needed, but they either had an MRI, evidence of sacroiliitis, or an elevated CRP, but a normal regular x-ray film as far as the SIs. But in the pre-SPA patients, they only met clinical criteria, but didn't have any MR or CRP. But it tells us then in that situation the importance of either the MRI or CRP if you're going to call someone a non-radiographic axial SPA. Well,
I think they summed it up nicely, and I think some of us thought, as the agency, the US FDA, was worried that non-radiographic axial SPA wasn't a thing, and that they didn't like the idea that it was pre-ankylosing spondylitis. And it turns out that it's not. And actually, Eric showed nicely, if you look, it's easy to distinguish people who don't have x-ray changes but really have the disease, and they respond to TNF inhibitors. But if you go a little bit lighter on the definition, you can have people who really don't benefit from TNF inhibitors. So I think we're saying that non-radiographic axial SPA is a thing. Radiographic axial SPA is what we call ankylosing spondylitis. Pre that, you get into trouble, and you can't overtreat based on softer clinical criteria, so someone just having inflammatory back pain.
But this is a hot area in our rheumatology. There's pre-lupus, there's preclinical RA, and the hot topic is, should you treat them or should you not? And I think right now the jury is out, which leads me to believe manage the symptoms, but don't start treating them as if they have the disease.
Okay. I think something else that and I have to say it was a little bit fortuitous because we have some excellent pediatric rheumatologists here at the meeting, Dr. Susan Chenoy and Dr. Ann Stevens. And last year, as we were putting together the topics, we said, well, you know what, macrophage activation syndrome, always an interesting topic that adult rheumatologists don't know enough about, and HLH. And then COVID happened. And so this became like about the hottest topic that I think we've had, and they did a great job of reviewing that and shedding light and also raising questions about the cytokine release syndrome and the Kawasaki-like disease that we see, the MIS-C. Crazy important area, and I think we're going to learn more about our diseases, about our treatments from following the COVID story.
Yeah, I'd encourage the audience to look at that video at RWCS.com when Artie posts it up. It's really a great talk about HLH and MAS, the overlap, they're pretty much the same. There are some genetic susceptibilities there. There's new clear guidance on what the diagnostic criteria are, and they really well outline the treatment options that are available there. So this is still a big area. You know, systemic JIA patients and adult stills, they're at much higher risk for MAS than really any other causes of MAS. So rheumatologists do have to know about this. And I want to say that Ann gave a great, she was the kahuna. That means that she's our teacher of the year. Ann Stevens, she did a fabulous lecture on the history of pediatric rheumatology that was, I thought, just breathtaking, showing how a few very concerned, well-intentioned, very smart pediatric rheumatologists can get together and make all the major advances that we now realize and live with today in rheumatology. What should we end with? I almost say that we should end with a comment about the ACR guidance that came out this week about vaccinations. You know, it's a tough issue.
Do you got an hour?
Yes. We got 4 minutes. So, so the ACR, led by Jeff Curtis, who was the lead of the task force, they did a tremendous job in 2 months in trying to review the non-data that's available, but come up with expert opinions on how our patients should be managed with regard to the vaccine. They said everybody should get the vaccine. And they basically said that you shouldn't change any of their DMARD therapies, and it's safe to continue almost all therapies, with the exception of very few. So it's okay to still be on IL-6 inhibitors and TNF inhibitors and methotrexate, and no, not methotrexate, all other DMARDs. But they gave an asterisk for methotrexate, JAK inhibitors, abatacept, and rituximab. What do you think?
Yeah, I think, you know, the old saying, Lord, protect us from people with good intentions. That they, I think, they meant well, but there is no data. And by putting this out there, I think it actually puts us in a tough spot. And Aaron Traum commented on that, well, this is out there. Now, it's not a guideline, but gosh forbid something happened to a patient who didn't stop their tofacitinib for 1 week before and 1 week after. And the reason to hold methotrexate for 2 weeks after, which they didn't get right, and the rituximab is that you'll get a lesser response, presumably, to this vaccine, although those data are from influenza. I think that they should have just ended with try to get your patients vaccinated and use your best judgment about what to do with the therapies, and maybe point out the older data, which is either from influenza vaccine or from pneumococcal vaccine. Not entirely irrelevant.
Yeah, the only data about good data about methotrexate blunting responses, not completely, but partially and variably.
A little bit.
Yeah. And so, and also variably. So that's why Park did the study showing that you should hold it for 2 weeks after the influenza.
Yes.
But again, good intentions went awry when they start extrapolating that to this situation, especially when you have to do 2 dose injections for the COVID vaccine. And then I think they went over the line with extending that to abatacept and JAK inhibitors, which I don't get at all, and I'm not going to practice that myself. Again, they are very clear to say that there's a dearth of evidence here, and that you have to use good clinical judgment in what you do. Talk to your colleagues, talk to the patients, make the best decision possible.
Maybe one happy note, and for anyone interested in diet, and everybody's interested in diet because all patients are, Dr. Traum did a very nice review, and actually, especially a lot at this past ACR meeting, there's a lot of controlled studies in diet manipulation and various outcomes in various rheumatic diseases. There's something there. I was actually pleasantly surprised that maybe you could even give recommendations in that way to your patients, because the Lord knows they want them.
Right, and if you can make evidence-based recommendations on diet, you're now king of the hill in rheumatology in your community. So anyway, that's it for this week's podcast. Tune in next week for more. Go to rwcs.com, that's r-w-c-s.com for these videos and more.